Picture a high-stakes forensic evaluation. A criminal suspect sits across from a clinician, suddenly claiming profound amnesia or reporting intense, vivid hallucinations. The clinician in that room faces a heavy burden. A false negative lets a dangerous criminal walk free, while a false positive denies a genuinely sick person the psychiatric care they desperately need. Often, the focus of the evaluation is malingering, the intentional behavior of deliberately fabricating or grossly exaggerating physical or psychological symptoms. The psychiatric community is clear on this distinction. In the diagnostic manual, the DSM-5, malingering is not classified as a mental illness. It receives what is known as a V code, marking it as an intentional action rather than a disease. Removing the disease label changes the clinical objective. In this room, medical expertise is being used to investigate a potential deception. The investigation begins with a process called differential diagnosis. Before assuming deception, doctors must systematically rule out any genuine organic causes, looking at brain scans and medical tests to ensure there isn't real neurological damage driving the symptoms. Once organic illness is ruled out, the investigation turns to human motivation. The clinician must determine if the person is driven by an uncontrollable psychological compulsion to be sick, or if they are executing a calculated strategy. Sometimes the deception is a recognized mental illness called factitious disorder. This is driven by primary gain, an internal, deep-seated psychological need to assume the sick role, even when it leads to painful, unnecessary procedures. Malingering operates on an entirely different set of rules. It is driven strictly by secondary gain. The deception is a tool used to acquire tangible, external rewards, like securing a financial payout or evading a prison sentence. This leads to a reliable behavioral tell. Fabricated symptoms usually vanish the moment the goal is achieved, or when the subject believes nobody is watching. Identifying that specific, tangible motive is the crucial dividing line. It marks the exact boundary between treating a psychiatric patient and catching a fraud. How does a psychologist prove someone is faking a cognitive deficit without using a polygraph machine? They rely on counterintuitive psychological testing, starting with a method known as the floor effect. These tests ask for basic personal history, or incredibly simple cognitive tasks. This chart shows how the floor effect works. The top line represents a baseline. These tests are designed to be so mathematically simple that even patients with severe brain damage pass effortlessly. But the second line shows a sudden, steep drop when a suspect takes the exact same test. Failing this specific type of test reveals a specific strategy. The subject is faking bad by overestimating just how impaired a brain-damaged person should act. Failing the simplest possible cognitive task offers the first measurable evidence of a calculated attempt to appear impaired. That leads to the most powerful weapon in the forensic psychologist's toolkit: symptom validity testing, or SVT. SVT relies on a forced choice mechanic. For every question presented, there are only two possible answers. This bar chart shows the statistical reality of random guessing. If a subject genuinely doesn't know the answers and guesses, their success rate stabilizes right at the 50% baseline. When a score drops to 10%, it breaks the statistical laws of random guessing. Scoring significantly worse than chance demonstrates that the patient actually knows the correct answer and is consistently choosing the wrong one to appear impaired. Clinicians also look for psychiatric deception using a strategy called rare symptom endorsement, often deployed in extensive evaluations like the MMPI personality test. These evaluations mix in preposterous symptoms that rarely occur together in real patients. This catches subjects who blindly endorse every bizarre symptom on the list in a misguided attempt to appear crazy. These psychological tests do not rely on a doctor simply spotting a lie. They leverage hard statistics and clinical base rates to render deception mathematically visible. Can a single psychological test definitively prove malingering in a court of law? The answer is no. A single test is rarely sufficient, largely because modern malingerers are becoming increasingly sophisticated. In some high-stakes cases, subjects are actively coached by their legal counsel. They are trained to recognize specific neuropsychological tests and taught exactly how to defeat them. Beyond coaching, clinicians must rule out innocent reasons for fluctuating test scores, like genuine test fatigue, physical pain, or comorbid medical conditions that interfere with concentration. This is why forensic psychologists rely on a complete picture approach. They synthesize psychometric test data with historical collateral records, auditing paper trails, school transcripts, and employment histories to see if the subject's past aligns with their current claims. They also rely heavily on behavioral observation outside the formal exam room. A subject might struggle to remember their own name during the evaluation, but correctly sign and date complex consent forms in the waiting room. There is an inherent limitation to this field. Short of a direct confession, achieving absolute 100% proof of another person's internal dishonesty is impossible. But by layering rigorous statistical tests, behavioral observation, and collateral data, forensic psychologists can confidently expose calculated deception. This ensures that justice is served and that limited medical resources are preserved for the people who actually need them.